Bismillah ar-Rahman ar-Rahim. Hi dear 5th year medical students. We will talk today about diabetes mellitus, which is one of the most important subjects. It is very common nowadays worldwide, not only in our society. So first of all, what's the definition of diabetes mellitus? It is a metabolic disorder and it is a chronic in nature, caused by either there is deficiency of insulin production from the beta cell of the islet cell in the pancreas, or there is defect in the action of insulin. So what's the manifestation of diabetes mellitus? Manifestation related to abnormal metabolism of the carbohydrate, fat, and protein. What's the normal value of blood sugar? Fasting blood sugar should be less than 120 milligram per deciliter, and postprandial or after a glucose load should be less than 140 milligram per deciliter. This is the normal values. So regarding the pathophysiology, what do we know about the normal glucose hemostasis? It is a process controlled by three interrelating processes, like first of all gluconeogenesis, which is the production of a glucose in the liver, and the second process is the uptake and the utilization of glucose by the peripheral tissue of the body, where it has to produce its function. And third, the insulin secretion. As we said, it is the product from the pancreatic islet cell. So the presence of glucose in the bloodstream, it will trigger the production and the release of insulin from the pancreas. We have to know the main function of insulin. What's the function? Function is to increase the rate of transport of glucose from the bloodstream into certain cells, like in the striated muscle and the fibroblast and the fat cell. So the transport is increased by presence of insulin, especially to the striated muscle, fibroblast, and the fat cell. Also, it is important for another transport of the amino acid and the glycogen formation in the liver and skeletal muscles. This is the function. And also the triglyceride formation from glucose and nucleic acid synthesis and the protein synthesis. The individual with diabetes and pre-diabetes, when there is a failure of pancreatic hormone release, failure of targeted cell to respond to insulin, or both, leads to blood glucose rises to abnormally high level. So if there is defect in the insulin, it will affect by increasing the level of glucose in the whole blood, and this will affect the function of the peripheral tissue. The classification, we have many types. Type 1, it is insulin dependent diabetes. Here we call it juvenile type. It is the main type in pediatrics. And here we have the random blood sugar is more than 200 milligram per deciliter. There is typical features of diabetes like polydipsia, polyphagia, and polyuria with decreasing body weight. Type 2, we call it the non-insulin dependent diabetes mellitus, and we call it the adult type. It is, of course, it is uncommon in children, and the fasting blood sugar or blood glucose is more than 126 milligram per deciliter, and as we said, 2 hours postprandial or post-glucose load is more than 200 milligram per deciliter in more than one occasion. The third type, we call it the secondary diabetes, whether it is insulin dependent or non-dependent. They may be due to syndromes, maybe due to drugs, or maybe due to pancreatic diseases. Syndromes, Turner brother Willie is a non-syndrome with diabetes. Drugs, mainly it is a steroid, and the pancreatic disease like cystic fibrosis or hemochromatosis. And we have the fourth type, we call it the impaired glucose tolerance test, and sometimes it is known as a pre-diabetes type. This measures the ability to use sugar after drinking a standard amount in sugary drink. Fasting blood sugar, glucose less than 140, and the 2 hours postprandial is more than 140, which is abnormal. So this is impaired glucose tolerance type of diabetes. And as we said, we call it the pre-diabetic. Gestational diabetes, here we have features of diabetes in a pregnant female, and she was not diabetic before pregnancy. That's why we call it gestational diabetes. Here, this is the normal level of sugar. If the patient is diabetic, after taking a sugar load, it will increases and never decline. Here we have decline, but after a long period, while in normal patient, 2 hours after taking a meal with sugar, it will decline. And patient with diabetes, it will not decline. The curve is remaining up. So the etiology of insulin dependent, we will discuss insulin dependent because it is the type common in pediatrics. It is well known. So it is multifactorial. Maybe first, number one, genetic predisposition. The higher incidence observed in people with HLA-DR3 and HLA-DR4. Also, there is immune etiology because there is a presence of antibodies against islet cell in 80% of patients. This indicates the association of insulin-dependent diabetes mellitus with an autoimmune disease, especially in celiac and in Hashimoto thyroiditis and others. Environmental factors like viral infection like measles, rubella, AB virus, they are blamed to initiate insulin-dependent diabetes mellitus, but in genetically predisposed individual. So as we said, insulin causes decreased blood glucose by decreased gluconeogenesis and glycogenolysis, and increased uptake of glucose by the cell, and it inhibits breakdown of fat, and we call it decreased lipolysis, and inhibit protein breakdown, we call it decreased proteolysis. Insulin deficiency, if it is not present, what will happen? There is hyperglycemia because, as we said, there is increased gluconeogenesis and glycogenolysis. So the glucose level in the blood is increased, and it is increased about the renal threshold, which is 180 milligram per deciliter, and it will be seen in the urine of the person or affected patient. So osmotic diuresis will occur because of hyperosmolarity, and this will cause polyuria and dehydration, and it will be compensated by polydipsia, excessive thirst, and they drink a lot of water. At the same time, there is an increase of proteolysis, and this will lead to loss of weight and excessive eating. We call it the polyphagia. And number 3, there is lipolysis because it is the compensated foul type, and here there is increase in the free fatty acid with accumulation of acetyl-CoA in the liver, and this will end oxidation occur there and will end with formation of the ketone bodies, and the patient will have ketonemia, ketonuria, and there is metabolic acidosis. So what are the presentation? As we said, for insulin-dependent diabetes mellitus, they got polyuria, polydipsia, polyphagia, and weight loss. And they may have secondary nocturnal enuresis because of they got polyuria with or without UTI, which is common in patients with diabetes. And sometimes there is insidious onset of vomiting, lethargy, abdominal pain. They got recurrent skin infection, and in female vulvovaginitis is common. Sometimes in 10 to 20%, diabetic ketoacidosis is the presenting feature. So what's the investigation? First of all, we have to check the urine for glucosuria and plus minus ketonuria. So there is high blood sugar in urine, there's high sugar in urine, and there is ketone in urine. Maybe 1 or 3 or 4 pluses according to the patient condition. And we have here the blood glucose fasting is more than 140 milligram per deciliter, and the random is more than 200 milligram per deciliter. Glucose tolerance test is of diabetic curve. As we said, it is still high after 2 hours postprandial dose of sugar. Glycosylated hemoglobin level, hemoglobin A1C, it is a reversible reaction between the globin chain and the glucose. It will be high, and it will be used for diabetic control in the last 2 to 3 months. If it is between 5 to 8% of hemoglobin, it is good control. And from 8 to 10, it is fair control. But if it is more than 10, it is poor control, 10% of hemoglobin. So how we treat the patient with diabetes mellitus? First of all, diet. Control diet is the most important part. We need the same total calorie intake because they are growing children and we need calorie. The calorie required is as a normal child, but in different ratio. The carbohydrate is equals to 50% of the calorie, 35% is of fat, and 15% of calorie required is protein. And we have to remember that carbohydrate should be given in complex form, in a starchy product and a fruit, and never refined sugar or sweets or carbonated beverages. This should be avoided. The number of meals also prefer to be 3, fixed 3, and there is 2 snacks in between. We have to remember in exercise, if there is severe exercise, we have to give excess sugar, or we need to reduce the dose of insulin. So in insulin-dependent diabetes, as we said, the treatment here is giving control diet and giving insulin. We have to know the type of insulin. How many types we have? There are a lot of, but we have to remember the 3 types. The commonest type, we have short-acting, we call it the regular, and here, this is the picture, we call it ectropt, and the onset within 1 hour, duration, it is 6 to 8 hours. Another type here, we call it the protamizing insulin, and this one is the onset within 2 hours, the duration 8 to 12 hours. And this is the name, Lintard. And the last one is the long-acting. It is act 24 hours, Glargine. And this is the pen type. And we have here the vial type. So we have the short-acting and the medium-acting, and we have the long-acting one. And this is the action. We have very short, very rapid acting. We call it the Aspart or Lispro. This is act immediately and should be given just before meal. It will act immediately within 10 to 15 minutes, and then it will decreases within 2 hours decrease and disappeared after 4 hours. And we have the regular, as we said, we call it the soluble type, and it increases the peak within 2 hours and disappeared within 6 to 8 hours. As we said, we have the protamizing insulin. The peak is started after 4 to 6 hours, and it maintains 12 to 20 hours. And we have this one, the green one, is the extended zinc. Its action peaks at 12 hours and extended. It will remain acting between 18 to 24 hours. And we have the glargine, as we said, it should be given before bedtime, and this will remain constant throughout the period. It is never rising, it will constant, and its action maintain 20 to 24 hours. So insulin therapy, how we can calculate the dose? According to what? First of all, according to patient condition and the age. And here, according to age, as we said, between 0 to 5 years, the dose required per unit per kg, it is 0.6 to 0.7 unit per kg per day. Between the ages of 5 to 12 years, the dose required of insulin is 0.7 to 1 unit per kg per day, and between 12 to 18 years, the dose required is 1 to 1.2 unit per kg per day. So the regimen of insulin therapy. The best method is mixture in children. We have to use 2 drugs at the same time, and we have to calculate the amount properly. We may use the regular insulin, as we know, we call it now soluble insulin, and the dose required is 1/3 of the total required dose. And the mixed protamizing insulin, it is equals to 2/3 of the total dose. So 1/3 of the total dose is soluble and 2/3 is of mixed, which is a medium acting. And how we give this mixture? This is the mixture. 2/3 of the total mixture should be given before breakfast, and 1/3 of the total mixture should be given before evening meal. This is the best method. There is another method. They use one injection of the long-acting, we call it glargine, but it is not recommended in children. We may use glargine with a very short acting before meal. Very short acting, as we said, we call it aspart or lispero. It should be given 3 times per day, but immediately before meal, just before meal, with an additional night dose of glargine at night. As we know, recently they can use insulin pump, and it is used here in Iraq again, use it. And there is inhalation insulin and nasal insulin and the oral insulin. But these are not used in pediatrics and they are under trial. So as we said, aspart, this is a very short and should be given just before meal with this glargine dose, which is covered 24 hours time. And we have other, which is intermediate acting, and also it covers, but you can see here the glargine is different. The glargine covers 24 hours and it will remain in a steady level. But when we use another type of insulin, it will peak in the middle of the day and decline later on at night. So it is not going to maintain a standard or a steady level. And we have the protamine, zinc insulin also. There are 2 peaks per day or 3 peaks. And we have different type of insulin, and each one it has its benefit and advantage and disadvantage. And here this time, this part, when we give regular insulin, we mean the soluble insulin, and we give overnight the protamine, zinc insulin. Here we have the complication of, as you see here, there is a period of decrease in the level of insulin per day, and this will cause hyperglycemia. So there is alternating period between hyper and hypoglycemia. The best way is to use the very short or very rapid aspart or lispero, as we said, with the glargine, which is, as we said, it will remain constant over the day. So how we follow the patient? First of all, we have to check the general condition, general health, for physical health, mental health, and sexual maturation, because most of these children, they got retarded growth and stunted growth and failure to gain full sexual maturation if they are poorly controlled. But if they are controlled well, they can reach normal sexual, physical, and mental maturation. Control of diabetes, we need daily monitoring of urine by doing urine strips. Okay, in the urine, there is dipstick for urine, and we have to check and monitor blood glucose by strips like this or by device. This is the device, and here we have the strip. This strip used for urine checking. And there are different colors, and each one means we can use to check different types. Here we have to check glucose, maybe ketones, and albumin in urine, and if there is other materials in the urine can be checked, and according to compare the result, we have to compare the result with this standard colors. And we have to check glycosylated hemoglobin every 2 to 3 months to give an idea about the level of control. Is it controlled, well controlled, fairly good or not? And we need health education of parents and also of older children about the disease and the complication, how to take the injection, how to store insulin, and many other complications. And we have to learn and inform the mother or the parents about this disease and the full picture of complication. We have to know, of course, the special consideration regarding therapy. First of all, we have to talk about the honeymoon period. Honeymoon period, after a period of well-being, after giving medication in form of insulin and the patient will start to improve the polydipsia decreases, polyuria decreases, and start to increase body weight. There is a period following partial improvement. There is a period of hyperglycemia, and this we call it the honeymoon period. Why this occur? Because residual function of the beta cell in the pancreas may be manifested at this time and manifested by hypoglycemia. Hypoglycemia occur after control of recently diagnosed diabetes, as the insulin is given in the same amount. In addition, there is residual function of beta cells, so it will cause hypoglycemia rather than hyperglycemia. This is the period normal insulin release. First of all, there is the reduction in insulin, then there is a normal insulin release because of what we said, because of honeymoon period. And during honeymoon period here, in addition to the dose of insulin given for treatment, and there is residual function of the pancreatic cell, will causes hypoglycemia during this period. We have to remember another phenomena. We call it the SOMOGI phenomena, especially in those who are taking high dose of insulin. It is more than 2 units per kg per day, as required to maintain a normal level of glucose. They will develop late night hypoglycemia at the time between 2 to 4 a.m. early morning. This hypoglycemia will cause stimulation of the counter-regulatory hormones like glucagon, epinephrine, cortisol, and growth hormone. And these will cause early morning hyperglycemia at 7 to 8 a.m. The treatment here, as we said, because they took a large dose of insulin, we have to decrease the dose of the nighttime intermediate insulin. This is the SOMOGI phenomena. As we said here, it was normal at early time. Here, if we give the injection earlier at evening time, there is normal glycemic level, but it starts to decrease to hypoglycemia at the time between 3 to 4 a.m. And suddenly, because of the counter-regulatory hormone, it will rises. And at 7 to 8 morning, there is hyperglycemia. So we call it SOMOGI effect or phenomena. What about the dawn phenomena? Here in the child who take insulin dose, which is low insulin at night, or maybe normal dose, but this low insulin dose or the normal dose is insufficient to counter the normal overnight physiological rise of blood glucose. As we said, it is normal physiology to have rises in these hormones in early morning. And when we check at 2 to 3 a.m., the glucose here, it is normal. There is normoglycemia. We call it late night normoglycemia, but early morning started from 3 to 4 a.m. There is the counter-regulatory hormones. They are rising, they increase in early morning, causing hyperglycemia. And in addition, as our child, they are growing, there is an increased secretion of a growth hormone during the early morning hours. And this will also add it to the morning hyperglycemia, particularly in middle adolescent. So treatment here, as there is low insulin night dose, we have to increase the dose of the night intermediate insulin to overcome this phenomenon. So in summary, SOMOGI is a rebound hyperglycemia caused by too much insulin, while dawn phenomena is morning hyperglycemia. It's caused by insufficient insulin to counter the normal physiological rise of glucose. And just to remind you, here SOMOGI is, as abbreviation, so much insulin. You have to put it in your mind. While dawn, there is down insulin as part of the pathology. And this is a diagram. It shows the down phenomena here. The cortisol growth hormone level is normal at 2 to 4 a.m. morning, but it starts to increase at early morning. So that's why we call the dawn phenomena. It was normal and then rises acutely in early morning. While SOMOGI phenomena, there is low blood sugar between 3 to 4 a.m. but it starts to increase immediately at early morning hours. And the treatment here in dawn phenomena we have to remember there is normal, but suddenly rise because of counter-regulatory hormone. We have to increase the dose of the night or the evening dose of intermediate acting insulin. While in Somoggy phenomena, as we said, there is too high insulin, so we have to decrease the dose. And this is another diagram, shows the same problems of dawn phenomena and Somoggy, and the difference here between the glycemic level, it was normal in dawn phenomena at 2 to 3 a.m., while it is very low, there is hypoglycemia in Somoggy phenomena. So we have to think about it during infection, what we are going to do. If the patient with diabetes got infection, what we have to remember, infection may precipitate hyperglycemia or DKA, so we have to treat infection. So we have to treat infection, and mild infection should be treated, and we have to increase the dose of insulin by 10 to 15%. If there is severe infection, it necessitates hospitalization. So now we will talk about the complication of insulin-dependent diabetes. We have acute complication and chronic complication. Regarding acute complication, there is coma. First of all, hypoglycemic coma because of maybe taking a lot of insulin. And the other type of coma, it is called the diabetic ketoacidosis, DKA, in which there is hyperglycemia plus ketosis. And the third is the hyperglycemic hyperosmolar non-ketotic coma, which is commonly seen in older patients, in adult, not in pediatric age. And one of the important complication is cerebral edema. This occurs during treatment because of hyperosmolarity, and maybe it is iatrogenic because of poor management, poor treatment, and poor correction of electrolyte. And the last one is cardiac arrhythmia due to hyper and hypokalemia. What about the chronic complication? First of all, as we said, there is delayed growth and stunted growth. It is a chronic disease. It affects the growth of the muscles, it affects the growth of skeletal muscle and protein deposition and the fat. Also, there is diabetic angiopathy, macro and micro angiopathy, and they result in nephropathy, neuropathy, and retinopathy, and into the blindness, which is very common cause of blindness. And we have defective immunity. There are recurrent infection, mainly UTI, fungal infection, and so on. So there is complication of therapy. We have to remember, first of all, hypoglycemia. If the patient took a lot of insulin, there is hypoglycemia. Sometimes local reaction like lipotrophy and lipohypertrophy. As in this picture, this is lipoatrophy or dystrophy, and this one in the thigh, hypertrophy. And hypersensitivity reaction, and this occur after giving insulin. There is a reaction at the site, or maybe it's generalized, and it's treated by change to the human insulin, not of animal type. Insulin resistance, usually due to insulin antibodies, is treated by increased dose. So we have hypoglycemia, local reaction, hypersensitivity, and insulin resistance. These are complications related to therapy. What are the signs and symptoms of hypoglycemia? We said the patient may have hypoglycemia. We have to inform and to assure that the patient or the parent, they know the signs of hypoglycemia before discharging home. So there is confusion, lethargy, drowsiness, dizziness, and agitation, difficulty speaking, inability to concentrate, focal neurological deficit, seizure, unresponsiveness, sweating, palpitation, anxiety, nausea, vomiting, tremor, and here, as we said, mood swing, trembling, pallor, blurred vision, hunger, dizziness, and so on. Just to remind you by this picture. Lipotrophy here and hypertrophy. This is hypertrophy in the muscles, and we have to remember the site of injection in the outer arm, in the abdomen, in the hip area, here, two sides, and in the thigh. And we have to insert the needle perpendicularly at a 90 degree angle, and it will be inserted to the subcutaneous layer, not to the muscle layer. And we have to change the site, although it is in the abdomen, but we have to change the site to prevent the appearance of lipotrophy and hypertrophy. in the thigh and in the abdomen. Thank you.